So our first talk is Dr. Kim. He's going to be looking at ways in which we could possibly in the future, or maybe even now, select and sequence therapies. Thank you, Alan, and good morning, everyone. So, as you saw in that case, and as my answer to the question was, usually we choose abiraterone or enzalutamide as first-line therapy for patients with metastatic castration-resistant prostate cancer. And although they both target androgen receptor signaling, they do so by different mechanisms. Abiraterone is a CYP17 inhibitor, interfering with production of ligand, testosterone, and of course enzalutamide is a direct non-steroidal anti-androgen. However, the story is perhaps a little bit more complicated in that it has been shown that through metabolism of abiraterone to 3-beta-HSD, it actually converts it to something called D4A, which actually interferes with androgen receptor as an androgen receptor inhibitor. So when we're trying to choose abiraterone or enzalutamide, which one do we choose first? When we look at the efficacy data, surprisingly very similar. The CUA 302 and the PREVAIL study looking at these agents in chemotherapy-naive patients. If you look across at the main primary endpoints, radiographic progression-free survival and overall survival, they're very similar. PSA decline maybe a little bit higher for enzalutamide. Median time to quality of life decline, very similar. Median time to chemo initiation, 26, 28 months. Median time to PSA progression, almost exactly the same, 11.1 and 11.2 months. And objective response rate was a little bit higher with enzalutamide, 59% versus 36% for abiraterone. So of course we kind of look at these, and we also look at the side effect profile for abiraterone, which is mostly because of the CYP17 inhibition, we get increase in mineralocorticoids, versus enzalutamide, we think about fatigue, seizures, that sort of thing. So we pick more based on side effect profile than anything else. What about sequencing? Can we use them one after the other? Kristen Noonan was a resident, reported on some of the first case series with this, as well as the group from France. And when we looked at abiraterone after enzalutamide, the response rate was very low, PSA response rate less than 10%. What about enzalutamide after abiraterone? There's a few more series that are looking at this. And we can just go right to the bottom, the Demono paper, which is the largest group, 215 patients. And there, the PSA response with enzalutamide after abiraterone was 27%, so higher, and a median time to progression for the whole group of 5.7 months. And they did describe some patients as having a prolonged response with a duration of over a year. So those were mostly retrospective studies, except for that last study by Demono, and looking at sort of second-line therapy, ABI after Enza or Enza after ABI. What about looking at ABI and Enza versus Enza followed by ABI? And there's a couple of studies that came out of Japan this past year that looked at this and retrospectively again. And when we look at the first-line data with abiraterone to enzalutamide or enzalutamide to abiraterone, as we suspect, the PSA response rate is in that 60% range. But when you go into the second line with the same patients, there is a higher response rate with enzalutamide, in this study showing a response rate of about 27% for enzalutamide after abiraterone and about 16% for abiraterone after enzalutamide. Now, putting that together, looking at the time to second progression on the graph on the bottom left, there seems to be a benefit in terms, at least for PSA progression, of abiraterone to enzalutamide. Makes sense. You know, with first line, we think they're pretty equal in terms of that time to progression. If you're eking out more of a benefit with using ABI to Enza, you're seeing some response there. However, in terms of overall survival, there was no difference between the different sequences. The other one was a Kyoto-Baltimore collaboration. They combined their data sets, and essentially the same thing. They're seeing good response rates first line with both agents, and then better response rate with enzalutamide after abiraterone. And similarly, the sequence of ABI to Enza, for at least for PSA progression, appears better than the sequence for Enza to ABI. But however, the overall survival was the same between both arms. So suggesting that you can get a progression-free survival benefit with one sequence, but not the other. However, this is retrospective data, it's biased, So we have to be careful in its interpretation. So after we're done with abiraterone and enzalutamide, what do we do next? The question is, how effective is chemotherapy afterwards? If we look at docetaxel after abiraterone, initially there was some concern that in patients that had resistance to abiraterone, that docetaxel would not be active. And that's because docetaxel may actually act on the androgen receptor by preventing its translocation by affecting microtubules. However, in a large retrospective study, 265 patients, the PSA response rate with docetaxel after abiraterone was 47%, which is almost exactly what the TAX-327 data was back in 2004, and a median time to PSA progression of 7.6 months. So this was kind of expected. Cabazitaxel is also effective. So this is now we're getting into third-line therapy, so after Abi, after docetaxel, and then now cabazitaxel, so third-line therapy. And if you look at the PSA response, it's about in that 30 to 40% range, which is again right on what we saw in the TROPIC study, which was cabazitaxel versus mitoxantrone. So it appears that chemotherapy is still active after our next generation hormone therapies. So to address some of the questions about selecting therapy and sequencing therapy, we actually in British Columbia designed and undertook this randomized phase 2 crossover study of abiraterone plus prednisone versus enzalutamide in patients with CRPC, and presented this at ASCO, just this past ASCO. So this is the study schema: patients with treatment-naive metastatic CRPC that were eligible for treatment with either Abi or Enza were randomized to receive abiraterone followed by enzalutamide or enzalutamide followed by abiraterone. The primary objective of this study was to look at the response and time to progression after second-line therapy, and at this presentation, at this analysis, we were looking at the effects at first-line therapy, and as well we took plasma and whole blood to assess for potential biomarkers of response. These are the baseline characteristics, pretty typical patient population. The enzalutamide group was a little bit older, 77.6 years versus 72.9 years for patients on abiraterone. However, if you look at all the other criteria or other prognostic factors, there was no difference between the two groups. Adverse events were as we would expect. So with abiraterone, we're seeing more hypertension, that's grade 3 or 4. We're seeing more hypokalemia because of its mechanism of action. Peripheral edema wasn't any different. And we're also seeing that 5% grade 3 to 4 toxicity with elevated liver enzyme tests, ALT and AST. With enzalutamide, we're seeing more fatigue. I don't show it, but the grade 2 fatigue was statistically significantly higher in patients with enzalutamide than versus abiraterone. And there was one patient with a seizure, so a 1% seizure rate in the patients on enzalutamide. This patient did not have any risk factors for developing a seizure. In terms of PSA response, it was higher with enzalutamide. PSA decline grade of 50% was 77% with enzalutamide versus 55% for abiraterone. And patients with no PSA decline, meaning primary resistance, was 20% on abiraterone, 10% with enzalutamide. This is not quite statistically significant. And you can see the waterfall plots there in terms of PSA declines. Time to progression, however, despite this difference in response, was no different. So this was time to progression based on confirmed PSA rise, clinical or radiologic progression, or death from disease, whatever came first. And time to progression was exactly the same for both arms, median 7.4 months, hazard ratio of 0.2. What we did incorporate in the study was trying to find some biomarkers of response. Who are those patients that aren't going to respond to therapy, for example? And then when we get into second line, we're going to try to look at who are the patients that will respond to therapy. And we do this using circulating tumor DNA from those plasma blood samples. We can take a tube of plasma and we can sequence the DNA within the plasma, and this gives us an idea of what the cancer genome is like. And this is just showing a display of the results that we have. So patients are individual columns, and then genes go along in the rows. And basically, we showed what we thought we would see, which is patients have AR amplification, P53 mutations, RB1 mutations, PI3 kinase pathway alterations, and also interestingly, more and more interestingly, is that we know that DNA repair alterations are very important in subsets of prostate cancer patients, and about 20% of patients have issues with this, so BRCA2 ATM. And what we showed is that these were correlated with outcomes. So patients, for example, with these BRCA2 ATM mutations, so issues with their DNA repair, had a very poor outcome. The median time to progression was 1.8 months versus 8 months for those without these alterations. Univariate analysis, hazard ratio 6.14, multivariate analysis 5.34. Why is this important? Because these patients may do better with chemotherapy. We actually have a paper in European Neurology earlier this year showing that these patients do badly with AR targeted therapy, but seem to do just as well with chemotherapy. There's also PARP inhibitors coming out of these patients. Cisplatin, carboplatin may work for these patients, and radium-223 may also work for these patients better, DNA damaging agents, and there's multiple case reports that we and others have put together. And so when it comes to that question of who should get the docetaxel chemotherapy rather than abiraterone and enzalutamide, instead of using clinical factors, I would hope that we would be able to use biomarkers to select our patients rather than just using our clinical guess. The other part of this study that we did was looking at quality of life and cognitive function, because there's sort of this element of fatigue that we all talk about with enzalutamide, and it never really been defined, and this was an opportunity to compare these two agents to see if there was a difference. And what we saw in the FACT-P analysis, which is a quality of life questionnaire, that at baseline the groups were the same, but at week 12 and week 24, so the total FACT-P, there actually emerged a difference that was clinically significant in terms of the degree of change. A 10-point difference is a clinically significant difference. So at week 12 in the AbbVie arm, there was actually an increase in the FACT-P total score, going from 115 at baseline up to 129 at week 12. While in enzalutamide, it stayed the same, 114, 118 in terms of the total score. And this difference seemed to be coming from things like physical well-being and functional well-being, which are subscores of the FACT-P. Looking at it in a different way, if we look at the patients that had a clinically significant worsening in the FACT-P or the physical well-being or the functional well-being subscales, on the left you see total FACT-P. So there was more patients that actually developed a worsening total FACT-P score at week 12 in the enzalutamide arm compared to abiraterone arm. And this, again, seems to be driven mostly by physical well-being at week 12 and week 24. We also saw some interesting changes in the PHQ-9 depression category. This is another patient-reported outcome where we saw patients moving from normal scores, but moving into scores that suggest a moderate to severe or moderate severe to severe depression category. And so we saw more patients in the enzalutamide arm moving to that versus abiraterone. So to be honest, I don't think these are actually new data. If you actually go back and look at the quality of life data from abiraterone and enzalutamide, it's very similar. If you look at the quality of life scores with abiraterone, it was increasing on the phase 3. In the phase 3 trial, and if you looked at enzalutamide, it flattened out. So I think what we do have here, though, is a direct comparison between abiraterone and enzalutamide. So just to summarize, for first-line CRPC therapy, enzalutamide has a higher response rate than abiraterone and prednisone. There's no difference in time to progression, and there's different side effect profiles and patient-reported quality of life between the two drugs, and therefore this adds some more information to how we can choose these therapies for our patients. Second-line CRPC therapy, there seems to be a low response with AbbVie after Enza, higher response with Enza after AbbVie, and maybe there is a better sequence, although it does not seem to affect overall survival. We will find out more from our study as it matures. Docetaxel and cabazitaxel are still active and should be considered in appropriate patients, and then prognostic and predictive biomarkers are really fully in development.